Good afternoon, everyone. Welcome to the annual general meeting of the Berkshire Healthcare NHS Foundation Trust. My name is Mark Day and I am the interim chair of the Trust, and it's my pleasure to host this afternoon's event and to run through the agenda of what we have in store for us. In a moment, I'll be handing over to Brian Wilson, our lead governor, who will explain the work of the governors over the past year. This will be followed by a presentation by Julian Ems, our Chief Executive, and Paul Gray, our Chief Financial Officer, talking through the performance of the Trust and our financial activities. We then have two service presentations. The first is from the Heart Failure Services outreach work in the community, led by Lucy Girdler-Heald. Now, Lucy and her team hosted me for a morning a couple of weeks ago at Upton Hospital in Slough, and they really are a tremendous professional team, and I was fascinated by the quality of the work that they undertake, so I'm really looking forward to Lucy's presentation. This is followed by the benefits of electroconvulsive therapy, or ECT, and that is going to be presented by Christine Jerica, who is our ECT lead. And then at the end of the day, we'll have a question and answer session chaired by Alex Guild, our Deputy Chief Executive. And then I will close the meeting at the end. So handing over to Brian, our lead governor.
Good afternoon. I'm Brian Wilson, lead governor on the Council of Governors and a publicly elected governor for Bracknell. And I'll be taking you through a review of the governor's year. Next slide, please. You'll see from the bottom left and the bottom right that we have well over 12,000 members of the Trust, 7,000 odd public members and 5,500 staff members. And you'll see from the top there that the role of the governors is to hold the board to account, not just the executive board members, but also the 6 non-executive directors as well. And we are part, under current NHS structures, of the independent public scrutiny that is in place on this particular trust and this part of the NHS, and in particular seeking assurance regarding the trust's performance in all aspects of that performance. Underneath the centre picture there, you'll see the makeup of the Governing Council. We have 19 public members who are elected by trust members. Our 6 local authorities are represented. Voluntary and other are 3, and staff are represented as well. I'll now go through the constitution of that personnel in the next slides, please. Next slide. Here are our public governors, and you can identify here the 6 constituencies, the 6 boroughs of Berkshire. If you want to contact one of your constituency governors, there will be an email address on the last slide at the end of my presentation. But I'd also like you now to draw attention to top right there, Windsor, Ascot and Maidenhead, where we still have 2 vacancies for governors on the council. And if anyone on the call is in that area, or even outside of the area, and knows somebody in Windsor, Ascot, Maidenhead who would be interested in being a governor with Berkshire Healthcare, then there is a contact email address again on that last slide of my presentation. Overall, we have a diverse range of people, different backgrounds, different skills, coming from different walks of life. So we have a very valuable contribution to make as a body of governors to scrutiny of the work of the Trust. Next slide, please. Staff governors are also elected, and 2 are from the clinical services side of the Trust's work and 2 from non-clinical departments. And they are elected by their fellow employees of the Trust. Staff governors as employees, in the same as all the employees, when they join the trust on their first day, they are eligible and enrolled into membership of the trust on joining. Next slide, please. The third group of governors we have are called appointed governors. The first 6 that I'd like to draw your attention to are the elected councillors from the 6 borough councils that currently exist within the county of Berkshire. The Council of Governors also has, as you can see on the right there, Reading University represented. We have a long and established relationship with the University of Reading on a research basis, and 2 charities are represented there as well. That in total makes up the membership of the council, and as you can see from these 3 slides, it's very encompassing in terms of the contributions that governors can make to the oversight and the conduct and performance of the trust. Next slide, please. Here you see a summary of the governor's meeting structure, where we have formal meetings, informal meetings, and subcommittee meetings, which I'll come to on the next slide. An interesting point where it says conduct formal business like appointments and receiving reports from the trust. In terms of reports from the trust, the governors receive the self-same data and information that the board does. There's no difference between the information we're given and that which the board operates with in its own right. In addition to the formal meetings, we have informal council meetings. They also take place 4 times a year. We then get to work with the executives and the non-executive directors in those meetings. It provides an opportunity for us to input to trust strategy and to get updates from the services. These meetings will often have, as the AGM has today, service departments in the trust presenting their work to the Council of Governors. Also in these meetings, as well as the formal meetings, it gives us an opportunity to raise questions, to challenge, to investigate, and ask for clarity and extra explanation of information presented to us. In summary, on the right there, you'll see our main areas of focus are patient safety, service quality improvement, and the Trust has a good track record in continuous quality improvement. Governors are involved in overseeing that. Of course, financial performance and membership and public engagement. Next slide, please. This slide here summarises some of the key things that we have focused on as governors in the year 24 to 25. I'll mention some details about some of them. Integrated care boards, this is to do with the NHS 10-year plan. Integrated care boards are changing. In the future, there will be fewer of them, and the governors are keen to continue working with the Trust to monitor these changes and to help the Trust adapt to the changing circumstances that the Trust operates in. The estate strategy is to do with our buildings, our fixtures, our fittings, and the management of the physical estate of the 94 operating units that we have within the Trust. Digital strategy. Berkshire Healthcare is a digital exemplar within England in the NHS and leads the way in a number of exciting initiatives at the leading edge of digital development. Strategy is something that governors are involved in. Although we're not allowed to make decisions on behalf of the Trust, we are consulted by the Trust and able to make a contribution to development in strategy discussions. CAMS, for those unfamiliar with it, is the Children and Adolescent Mental Health Services. The Trust is highly active in developing and promoting anti-racism. The Silver Cloud presentation was about an online platform of structured treatment programs that can be accessed by members of the public and patients. Staff survey, it's very pleasing to see that each year Berkshire Healthcare has been very, very high up in the league tables indeed in the National NHS Staff Survey results. The Carers Strategy is an ongoing piece of work where the focus isn't just on the patient, it's on their carers and their family members or both, and is looking at ways of making sure that a full perspective is gained to deliver the best service and treatment to the patient. Next slide, please. We're also involved with the appointments at non-executive director level on the board. And here's an illustration of some of the things that we've done in this particular year. We extend the terms of office for certain non-executive directors. The reason for this is that we want to have continuity of service and not to have too many vacancies or too many new non-executive directors at any one time. It preserves the talent pool and the contribution that non-executive directors make to the board. We extend the terms of non-executive directors which are up for reappointment. The terms are 3 years long, and here we've reappointed Professor Sally Glenn to her 2nd year. We conducted the recruitment process along with the Trust, and we're delighted with the appointment of Sonia Batcher as a new non-executive director to the Trust. Mark Day, who's chairing proceedings today, has been promoted, if I can use that word, I hope he doesn't mind, from Vice Chair to Trust Interim Chair, as we continue to work with external recruitment providers to appoint a new chair of the Trust. We're also involved in the discussions which are performance reviews and remuneration reviews for chairs and the chair and non-executive directors. Next slide, please. We have 3 subgroups that meet periodically throughout the year. The Quality Assurance Group pays detailed attention to things like patient feedback, compliments, complaints, waiting list data, and a whole host of other performance metrics and information. The Membership and Engagement Group, it is part of the Governor's role to seek contact with the public and seek feedback and involvement from the public about the work and services of the Trust, and in particular to promote membership in those areas where we're underrepresented in certain membership categories within the membership overall. Living Life to the Full looks at the wider aspects of health and well-being and receives presentations from external partners and organisations about their work with patients and other members of the community, and in particular where their work overlaps with or is complementary to the work of the Trust itself. Next slide, please. Finally, 2 important things to remind. The Trust, like the whole of the NHS, continues to face very challenging times, especially workforce and funding issues, but I've also mentioned the changes to NHS England in the NHS 10-year plan and the local government reorganisation that will take over from where Berkshire Borough authorities are at the moment. We don't know the shape and size of that. So challenging times, I think, should be in capital letters, really, because there's going to be a lot more to contend with. There'll be much for the Council to follow in maintaining oversight on performance and to ensure that the needs of patients, their families and carers are kept at the forefront of decision making. It's very fundamental to the Trust that patients, families, care, performance and patient safety are very much focused on, and the governors are part of that. As I mentioned, if you're interested in becoming a governor, here's the email address that you can use, our Company Secretary, Julie Hill. And if you want to contact one of your own constituency governors, then the email address is here, governor@berkshire.nhs.uk. It would be helpful if you could put the governor's name in the subject line of the email. Thank you very much for listening.
Performance. That's the financial year starting April 2024 through to March 2025. It's inevitably a high level report and summary, but very happy to take some questions. It'll be followed by the Chief Finance Officer, Paul Gray, doing the financial aspect of the year. There's some elements of my presentation that are prescribed in terms of things that we have to cover off legally in terms of the annual report. What I would say is, if you want to know more, the annual report is available on our website, and it does obviously go into much more detail. I would also always recommend, if you're interested in the detail, the trust quality account. That's probably the thing that I often go back and look at and dip into, because it really does give you a real insight into the detail of what's going in the trust. So with no further ado, just if we move to the next slide, really, the first slide is really just an introduction to Berkshire Healthcare. People often get confused about the NHS landscape because it is complicated. There are two organisations with Berkshire in the title, the Royal Berkshire, and ourselves, Berkshire Healthcare. We are the provider of all mental health services and community physical health services in the county, and we also provide some specialist services further afield. Next slide, please. So during this last financial year, prior to the publication of the government's 10-year plan for the NHS, the Secretary of State emphasised three big shifts that he wants to focus on. So first shift was a shift to prevention, recognising that the NHS predominantly has been a treatment service and wishing to move towards preventative care to improve long-term health outcomes. Secondly, to move to community-based care like we actually provide as an organisation. So this is very relevant for us. So transitioning from acute hospital care and only doing things that absolutely need to be done in an acute hospital setting, and moving it to community-based services often provided by the voluntary sector, organisations like ourselves, and primary care, really centred on local populations and making it as accessible as possible. And then the third transition is into digital. So moving from analog to digital is the soundbite, but really exploiting the potential of digital technology. And as Brian said in his governor's introduction, we are well placed in terms of that. So nationally, there is an index of digital maturity of all 200 and odd NHS organisations and providers, and we're number one in the country. We've been working on a clear digital strategy for some time, and I'll touch briefly on the impact of that in one particular area later on in my presentation. And then again, Brian touched upon this, is that there was announced last year that there would be a significant change in the way in which the NHS landscape was conducted, and that includes the abolition in a year's time of NHS England, and that will be merged effectively with the Department of Health, so there won't be two separate bodies, there'll just be a Department of Health and Social Care, and also that would be a halving of number of integrated care boards. And also that they would also reduce in terms of their headcount. So we now know retrospectively that there will be one integrated care board that will be in the planning footprint of, and that will be the Thames Valley, with the coming together of the East Berkshire bit of Frimley and the Buckinghamshire, Oxfordshire and Berkshire West ICB. Next slide, please. So if we were to summarise at a high level, and remember I am just doing this at the highest possible level, we had a good year on many fronts. We were able to maintain strong clinical care standards, and as I said, the quality account really sets out some of that detail, but particularly in terms of patient safety, such as reduction in falls, pressure sores, and an increase in patient satisfaction from our patient experience tool. As I say, if you want to know more, please look into the quality account. We also made significant progress on waiting lists, something we've been focusing on sort of post-pandemic, really. So really driving down some of our long waits, with one exception, and that's in relation to neurodiversity assessments. We have doubled the number of assessments we're doing in the last 4 or 5 years. So yes, a doubling of those assessments, but actually the demand is more than doubled. And this is a national problem. And indeed, there has now been established an NHS national task force to try and seek some solutions to what is a nationwide issue. Finally, in terms of performance, we, in addition to the clinical standards, maintained a high level of financial stability and performance. And Paul will go into the detail of that, but we're a small number of organisations that have managed to break even. And because of that performance across the board, subsequent in the last few weeks, the organisation has been placed third in the national league tables for community and mental health trust providers. And in segment 1, you may have seen that when the league tables were published just a couple of weeks ago, but it was based on the performance that I've just talked about over the last financial year primarily. Next slide, please. I talked about the emphasis and the move from analog to digital. Just one aspect of that, or two aspects of that, I'll home in on. The first is that we've increasingly been able to automate processes, particularly administrative processes, using automation and robots, software robots. And that's really been able to offer us a level of efficiency and reduce operational burden. So we had a presentation recently from our community nursing colleagues who are using that to triage many referrals that come in. Our physiotherapists have done the same to great effect. And so the impact of this is really starting to be felt, and it's something that we're going to be ramping up in the coming years. We're also very fortunate that across Berkshire we have a thing called Connected Care, which in the first instance is a joining up of records. So the joining up of records, NHS records and social care records in the area, so that we're able to see at a glance, if you're a clinician in our organisation, relevant details from the acute trust, Royal Berkshire and Frimley, the GP record and social care record, as well as ours. And that is obviously great in the moment, but also it allows us to do some analysis of the population we're serving and be able to identify people who are maybe at particular risk of particular diseases, people who may not have had comprehensive physical health checks, who are at risk of those diseases, and allows us to instigate interventions in order to address potential health inequalities. And that line of work and that focus in the future will only grow in terms of the power. And again, it's entirely consistent with what I set out early on in terms of the government's 3 shifts in terms of the healthcare setting. Next slide, please. Again, Brian touched upon this. I guess the point I would make is now for the last decade or so, the culture in the organisation has been a positive one. That's not me saying it. Every year there is a national staff survey. It's extensive. It's the world's biggest. The results are published and compared. And we feature amongst the very best organisations in the country for satisfaction, levels of engagement, levels of morale. And we're really proud of that, not just because of last year's achievement, but the fact that actually the results were even better than the previous years, which themselves were right at the top of the table nationally. We're also pleased that we've continued to make improvements for our Black, Asian and ethnic minority staff, which highlights the success of our anti-racism programme, making sure we're promoting equity and inclusion. But there is still more to do, and we still have significant elements of racial abuse persisting, particularly in our mental health inpatient unit, where it's explicit, but in other areas and other walks of life. These are terrible acts having a really detrimental impact on our workforce and other patients who are witnessing it, and we're determined to do more about that. So there is more to do in that space, that's for sure. Next slide, please. Part of what we've been doing and part of our success, and if you look at those 3 shifts, working collaboratively with the voluntary sector, with social enterprises, with other NHS organisations and social care and primary care is key to the delivery and the way in which we work. And that has been indicative of last year, but I would say that's getting ramped up even more in order to fix some of those big issues that we've got. And as I said, Alex Guild, who's our Deputy Chief Executive, has been actively helping shape in shadow form the development of the Thames Valley Integrated Care Board, although that was only officially announced in Parliament as having been rubber stamped and going ahead. the plans and preparation for that have been some time in the making, and pleased that Alex and other colleagues have been helping to support people in terms of making the development of the Thames Valley ICB as smooth as possible. For those people who don't know, ICBs, Integrated Care Boards, are the bodies responsible for planning and funding healthcare in a particular geographical area. Next slide, please. So penultimate slide, just to acknowledge some exceptional achievements that came to an end during the course of the last financial year. So Dr. Minu Hirani, who was the medical director for many years, retired from post. I'm pleased to say, though, he was appointed a non-executive director of the Royal Berkshire Hospitals NHS Foundation Trust, so strengthening collaboration there. In his stead, we recruited Tolu, who became the new medical director in April. He came from Tees-Eskin Weir NHS Foundation Trust up north, so great to have someone else bringing some fresh insights into our team. Our Chief Operating Officer, Tamina Ajmal, moved to the Welsh NHS, and Teresa Wiles has been appointed our Interim Chief Operating Officer. Teresa's worked for us for many years, thus ensuring a nice level of stability amongst our executive directors. We said farewell to Naomi as our former Finance and Performance Committee Chair, non-exec director, after much long service. And it was a pleasure to welcome Sonia Batchelor as a replacement. And then finally, in terms of comings and goings, a huge thank you to our long-standing chair, Martin Earwicker, who'd done a truly remarkable job in helping shape the organisation over nearly 9 years. He stepped down at the end of his term after 9 years. He's still in contact, still in the NHS. He's moved to the chair of the Hampshire Hospitals Trust. I spoke to him only on Monday, so he's around and about, but what a contribution he made to Berkshire Healthcare. Thank you, Martin. And then final slide for me. So with all of that on, and Brian talked about at the end of his slide, really some of the challenges that we have got. What I'd say is that's absolutely true. The performance of the NHS really under the microscope, big reorganisations taking place, many moving parts. But if you've listened to what I've said, and in terms of whether the direction of travel of the NHS, I think we're well positioned to face the future challenges. We've got a great track record of delivering. We don't always get things right. When we don't, we're quite good at acknowledging that and putting them right. And we've seen year-on-year improvements. So all in all, it has been a good year for Berkshire Healthcare. Thank you all for your support. It is much appreciated. I'm now going to hand over to my colleague, Paul Gray, who's just going to briefly give you a flavour of what was happening with the financial performance of the Trust, which again is a requirement of the AGM. Over to you, Paul. Thank you. Paul, are you on mute? Hi, Paul. We can't hear you. We can see you. You're going live, but sorry, we can see you but can't hear you, Paul. Maybe you've got some IT issues.
Is that any better?
Yes, Paul. We can't see you, but we can hear you, which is preferable, actually.
Is that better? Have we got sight and sound now?
Yes, thank you very much, Paul. Relief, sigh of relief. Just testing it out, aren't you?
Brilliant. So thank you. We'll start again. So good afternoon, everyone. I'm Paul Graham, Chief Financial Officer. Apologies for the IT gremlins. So I'm going to take you through a quick high-level overview of how the Trust performed financially over the last financial year. So if I can just get the next slide, please. So just to outline what we expected to do in 24-25. So the trust planned for a financial surplus of 1.9 million. So ahead of and higher than the expectation of break even, and that in part was to contribute and help support the Buckinghamshire, Oxfordshire and Berkshire West system achieve a break-even financial plan. And to do that, we plan to deliver 13.6 million of efficiencies. We planned to spend 15.6 million on capital. In terms of capital, what we mean by capital is material spend on buildings, equipment, IT kit and infrastructure. And with that level of capital investment and the level of surplus, we expected during the year that our cash surplus would reduce by 5.8 million. So if I can just move on to the next slide, please. So in terms of our actual financial performance, I think it's with great thanks to all of the staff at the Trust who continue to focus on keeping tight control over our finances. So we managed to deliver the original 1.9 million surplus that we set. In addition, last year, following the final reconciliation of our activity performance, we were in receipt of an additional £3 million of elective recovery income, which we'd not planned for in our 24-25 plan. So that was a bonus, and this is income specifically related to activity we do to reduce our waiting lists. So combined, we delivered a surplus of 4.9 million against our original plan of 1.9. You'll see from the slide that we saw quite a level of funding increase or income growth in 24-25. This is a result of national price inflation that we receive on our NHS and other contracts, and specific funding for employers' pension contributions, which we saw an increase to. We also received additional funding through the Mental Health Investment Standard, which is a specific stream of funding to support and increase services for our patients, and some service development funding, which again we use combined to help expand and develop services, and we were able to use it to open Poppy Ward, which is our new inpatient bed facility. We also, as Julian said, continued to make good progress on our waiting lists, and that resulted in higher than expected levels of income for the activity that we delivered. Whilst our funding grew, our cost base also grew, and that reflected nationally agreed pay awards and inflation on other costs. We also have a workforce plan, and that plan was to increase the workforce in line with the investments that we'd agreed with our commissioners. And we saw an increase in our workforce of just short of 240 staff during the course of the year. But at the same time, we continued our commitment to reduce our temporary staffing spend, and we saw a 4% reduction in our agency spend, and continued to manage costs in line with the ceiling that NHSE had set us. In terms of capital expenditure, we didn't quite spend the 15.6 we expected. There were some delays to the development of our new POS facility at Prospect Park, which is opening in the coming weeks. We also had delays in signing a couple of property leases, which again have fallen into this financial year. So against the 15.6 million plan, we spent 12.8. 5.9 of that was on developing our estate. So we consolidated some properties in the Reading area and have made some notable improvements to Whitley Clinic. We built a new dental suite at St Mark's in Maidenhead, and at Prospect Park, although we didn't complete it, we did make substantial works on our new place of safety, which, as I've said, is due to complete imminently. And then we made a number of other upgrades and health and safety works across our sites, which obviously span the entirety of the county. And then we spent a further 6.9 million on estates upgrades, equipment, and reinforcing our digital infrastructure. Our better than anticipated surplus position, the slight reduction in spend on capital than what we planned, actually meant that we finished the year with a higher than expected cash position, and that increased by 1.4 million to 54 million, which obviously we can use to continue to invest in our estates and IT infrastructure. Importantly, we went through our annual external audit process with Ernst & Young, and we got an unqualified audit opinion, which gives us assurance over our financial reporting, which is really positive. If I can just have the next slide, please. And if we just look forward to this current financial year, we've again gone better than break even in terms of our financial aspirations, and have set another surplus plan for the year ahead at 1.9 million surplus. To do that, the efficiencies have got a bit harder, the ask has got a bit harder, and we're aiming for 17.5 million of efficiencies to be delivered this year, more than half of which we expect to be recurrent and impact in future years as well. We've increased our capital expenditure programme, taking into account expansion of works and new leases we need to sign this year, and they're expecting to spend just shy of 23 million during the course of this year. And given that increase in capital expenditure, we expect the cash that we hold to reduce during the course of the year by 7.1 million. Thank you.
Good afternoon, everyone. My name is Christine Zarita. I'm the ECT Deputy Lead. The manager is Janet Waro, and we work closely with and report to Michelle Mbaewa, who is the head of service for inpatient at Prospect Park Hospital. I'm looking forward to sharing some insights from our service and highlight the benefits of ECT. ECT stands for electroconvulsive therapy. Next slide, please. ECT is a medical treatment where a small electric current is passed through the brain under general anesthesia to trigger a brief controlled seizure. It is nowhere to how it used to be done in the olden time, it is said. This process causes changes in the brain that can rapidly relieve symptoms of certain mental health conditions. I will touch at a few conditions as we progress in our presentation. Next slide, please. Key benefits of ECT. Number one, there's high success rate. ECT has a 68% success rate in treating severe depression, especially when medication has failed. This information was obtained from the Royal College of Psychiatry, where all the clinics that are registered with the actors, they enter their data set and they gather all the information. Also in our clinic, we do some audits and our success rate has been above 70%. Number two, rapid symptom relief. Many patients experience improvement within days or weeks, making it one of the fastest acting treatments for severe depression. Antidepressants, they take about 4 to 6 weeks to work, so ECT is quite effective and quick acting. Next slide, please. Number three, it's effective for treatment-resistant condition. Major depressive disorder. Majority of our patients are treated for depression. It's also used to treat catatonia and severe mania, and we have noted that it's quite effective when we are treating these patients. Normally, they'll require 4 to 5 treatments, and the patients get better and they continue with their treatment plan. Medication-resistant schizophrenia. Normally, it's not first-line choice of treatment, but in patients where the team have struggled to engage the patients, they're not engaging in the treatment plan, ECT has proved to help in allowing the patient to become more lucid, more engaging, and then start to accept the treatment plan. Next slide, please. Number 4, it is safe. It is performed under general anesthesia with muscle relaxant, making it safe and controlled. It is administered in a strict medical guidance. So the anesthetist who comes from rare Berkshire, so there's a specialized team that is involved when you're giving ECT. So we have the anesthetist, we have the operating technician, and some they call them ODP or operating department practitioner, and we have a recovery nurse. These 3, they come from Rare Berkshire Hospital. We've got a contract with Rare Berkshire Hospital. So the anesthetist, the ODP, and recovery, they come from Rare Berkshire. The ECT practitioner, these could be a psychiatrist or nurse who is trained in administering ECT. In our clinic, myself and my manager, we are trained in administering ECT. So we are ECT trained nurses who give ECT. Also, we have ECT nurses. So when we are giving treatment, we have to have at least a minimum of 5 staff unless we have observers who then come in the clinic. Next slide, please. The process of ECT. Before ECT is given, the patient has to have a physical workup, which includes blood test and ECG. These are the 2 main ones. But normally, depending with the condition of the patient might have other underlying physical health problems. So in that instance, the patient might need to go under further investigations, such as they might need CT scan, they might need MRI scans. Sometimes they might need to be seen by a specialist. It could be a cardiologist, a neurologist. So once the anesthetist is happy with the results, the patient then is ready for treatment. Because of the anesthetist, the patient cannot eat or drink the night before ECT, so the patient has to be kept nil by mouth. Then consent is obtained. For patient who has capacity, they just sign their own consent and they'll come for treatment. And they are also able to withdraw their consent at any time. Patients who lack capacity, they will be treated under Mental Capacity Act or Mental Health Act. Anesthetic drugs administered intravenously. These are to help to sedate the patient and also to relax the muscles in order to prevent any injuries. All physical vital signs and brain activities is monitored. So during the treatment, blood pressure is monitored, heart rate is monitored, breathing is also monitored. So during the procedure, all these vital signs are monitored. Next slide, please. After ECT, the patient is in the recovery room within 10 minutes of treatment. When they go in the recovery room, they stay in there for about 20 minutes until they gain consciousness. Once they are alert, they move to the recovery room. Once they're in that room, they still continue to be monitored their vitals. Once they are fully awake and ready to have something to eat, they are offered refreshments so they can have anything. Normally we offer like cornflakes, Weetabix, that kind of breakfast, so that we make sure they are able to eat and drink before they are sent back to the ward, if they are coming from the ward, and if they are coming from the community, they are discharged back to the community with a responsible adult. Next slide, please. Side effects of ECT. ECT is just like any other treatment, it's got its side effects. One of the side effects is headache. So patients complain of headache after ECT. Normally, majority of them, the headache goes away after a few hours. But if the headache is persistent and continuous, we advise patients to take paracetamol to help with the headache. Muscle aches and nausea, normally these are from the anesthesia drugs that they take. Normally we give propofol, that's the medication, and saxophenia. So sometimes they complain of muscle aches. And after 1 or 2 sessions, most patients will stop complaining of any aches. But if the pain continues, we also recommend them to take paracetamol. Tiredness, this is generally from the seizure that they would have had that causes the tiredness. Normally, by the end of the day, the patient is back to themselves. And normally, we advise patients not to sign any documents or making any life-changing decisions after the treatment. Confusion, also a few hours after treatment, some patients complain of confusion, but it goes away. Memory issues, these are transits. We also monitor the memory. We use a tool called 6CIT. If the memory continues and it persists, we might change the lateral of the treatment. But normally, some patients after a few treatments, they report that their memory is getting better. But if they continue to be an issue, we might then stop the treatment. Also, to just make it clear that ECT does not lead to permanent memory loss or dementia. Next slide, please. Addressing misconception. Media portrayals have often been inaccurate and stigmatizing, especially at the old films and horror movies. The way they portray it, ECT is nowhere to how it's done now. Modern ECT is nothing like the outdated depictions in the film. It is safe. ECT is a scientifically validated human and life-saving procedure. I have seen ECT where we have administered ECT at rare Berkshire for patients who were declared like end of life, and after discussion with the MDT, they've agreed to offer ECT as a last resort, and they've seen patients who have recovered and they got discharged home. So ECT is quite effective and it's a life-saving treatment. Next slide, please. When is ECT used? So ECT is administered in emergency situations where severe symptoms must be treated rapidly, e.g. if a patient is suicidal risk, there's poor oral intake, such that if the patient continues not eating and drinking, they might end up dying or something serious will happen to them, or their electrolyte imbalances. So in that instance, ECT is quite effective. Severe soft neglect. It is offered in treating severe illnesses such as depression, mania, and catatonia, when it has worked in the past. So if the patients have had ECT in the past and they have reported that they would like to have ECT because it has worked for them, so when a person also requests ECT. When medication unsafe or have bad side effects, so some patients might be experiencing bad side effects from medication and then they opt for ECT. When other treatments such as medication, talking therapy have not worked, we then offer ECT. Next slide, please. Who monitors ECT? So ECT is administered under Mental Health Act 1983, Section 58. We also give ECT under NICE guideline, which was updated in September 2023. So it's not a matter of somebody just coming and say, I would like to give ECT to our patients, but we have to look, is it within the NICE guidelines? Also, Royal College of Psychiatrists Accreditation Service. So who monitors the clinics and sets national standards for ECT. So our ECT is accredited, our clinic, and we normally have 3-year review and we are due for our 18-month interim review. We follow trust policies and also we follow our ECT policy. Next slide, please. ECT governance. The clinics are accredited by Royal College of Psychiatrists. We have regional meetings. So we are a member of Southwest County Group, where we are about 6 clinics that come together. And our chair takes any feedback to the ACTAS and NEONECTA, which is the National Association of Lead Nurses for ECT. We have 3-year accreditation with intimately accredited process, like I mentioned earlier, and we do annual data sets. Also, we do internal Berkshire healthcare audits. So some of the audits we do are like ligature audits, health and safety audits, we do infection audits, infection control audits. We do governance reports. We prepare a 3-monthly report to the mental health. We also do annual audit. We do CGI audits, and we also do consent audit of our treatment. We do monthly ECT governance meetings, and the trust managers are invited to attend. We do monthly statistics collection, which we look at the locality of the patients we are treating, their ethnicity, sex, the number of treatment that they've had. So in terms of ECT governance, those are some of the things that we do. Next slide, please. In conclusion, ECT is a treatment option with a high success rate, rapid symptom relief, and effective for treatment-resistant conditions. It is safe, modernized, and alternative to medication, and it also can be given in conjunction with medication. Addressing misconception is crucial to understanding the true benefits of ECT. Thank you very much.
Okay, Lucy.
Hello, thank you for having me this afternoon. It has been a little bit of a computer nightmare, but I'm here. My name's Lucy and I'm the lead for the East Berkshire Heart Function Service, and I just want to talk to you about the Heart Failure Service's approach to health inequalities. Next slide, please. So why did we feel the need to have a look at this? All the research has shown that in the UK, the mortality from heart disease in Asian men and women is 1.5 times higher than that of the general population. Asian men and women have higher rates of diabetes, hypertension, high cholesterol, and obesity. And all of these are leading causes of heart disease. They're also less likely to receive specialist appointments, and that includes implantation of devices like pacemakers and cardiac surgery like valve replacements, coronary artery bypass grafts. We've also noticed that the do not attends at clinic are very much higher in this cohort of patients. And as we covered SLOW, we felt that this is really important to have a look at. Next slide, please. So we really needed to understand why. Why were patients DNA and not attending their clinic appointments, not getting clinic appointments? So we spoke to all the community leaders. We also met with Wexham Park Hospital and the Slough MP, Mr. Tan Desi. We also, every time a patient didn't attend a clinic, we phoned them to find out why. The reasons included the language barriers, economic factors like unable to get to the hospital, unable to get to clinic, they had no one to bring them, a lack of understanding of why they'd been referred to us, why they had to go, did it really matter? They didn't really trust us because they didn't know us. And our lack of knowledge on their customs, we spoke to people and spoke to them about, how would you feel we could help you? And they said, well, you can't because you don't understand us. Next steps, please. Next slide, please. So we decided to take the health buses, our beautiful buses, out into the local community. We were aiming to reduce inequalities, improve our do not attends, improve our joint up working with Wexham Park Hospital. Also, we could get out, meet the people, improve their access, hope they had trust in us, improve our knowledge. And we could also give proactive heart health education. We could also find people with undiagnosed hypertension and also underdiagnosed CVD disease, so cardiovascular disease, using echocardiogram. Next slide, please. So we had 2 buses. We had the health bus and we also had the valve bus. On both of these buses, we took blood pressure recordings, heart rate, heart rhythm, SpO2. We also have an Alive core, which is a very easy two-fingered approach to doing a heart rhythm. Listen to lungs, and if the patient needed one, we did either an ECG and or an echocardiogram, and all of the attendees filled out the questionnaire. At that time, with us, as well as us heart failure nurses on the bus, we had 2 consultant cardiologists from Wexham Park Hospital, 3 cardiology registrars. We had a specialist valve nurse, a specialist arrhythmia nurse, Medtronic, who sponsored one of the buses. We also had Valve UK, which are the local charity for valve replacements, and we did a massive social media campaign. Next slide, please. This is our social media campaign. We did 5 interviews, 4 on the radio before the event, and 1 evening news story on South Today. We were in 4 national and regional print newspapers, including the most read Asian newspaper, the Eastern Eye, and we had more than 10 event listings and shares on our social media platforms. Next slide, please. And this is what we did. So I was separated it onto the 2 buses because they were totally different people seen. On the health bus, we saw 319 people. 182 of them were male, 164 were female. Of that, 123 were white British, and in other ethnicities, there were 196. Out of those patients, 167 people had undiagnosed hypertension. They did not know they had high blood pressure. High blood pressure happens to be a silent killer, so it's really important that they knew that they had high blood pressure. We managed to catch 13 heart failure patients that needed a review. And atrial fibrillation, we managed to catch 3, which is an abnormal heart rhythm. We did ECGs on 15 of those patients. And there were other issues like that were totally unrelated to cardiac that we were able to see. All patients got letters to go back to their GP with them, or we actually made them see the cardiologist on that day. On the valve bus, we screened 256 people. Male 114, female 144, 129 were ethnic minorities, so another 50% on both sides. 3 had aortic stenosis, and that's so one of those was critical, so they had surgery, a valve replacement within 7 days. 3 more atrial fibrillation, 1 moderate aortic regurgitation, and 1 mitral regurgitation, all that saw a cardiologist or a cardiology registrar on that day. Next slide, please. So what's next for us? Now we've noticed that we've been doing this in Slough, so we've probably created an inequality as well. So we have decided we are going to take our buses to every area. We are going to Bracknell and Windsor and Maidenhead and Slough next year, so we're going to each of them 4 times a year. We have we are continuing to visit the community health groups. We have also set up a support group that the heart failure nurses are running once a month for education and enabling patients to get together, and we hold that in Windsor with all different kind of educational events. We do a 3 monthly newsletter to keep all patients informed of what is happening with our team, where we're going next, where the next health bus is going, education. And we've also decided that this time we are going to start learning other languages. So we've got 2 nurses learning other languages, a couple of us doing sign language. And so it's quite an exciting time. And we are also have a stall on the community day in next week, I think it is, or the week after. So that's what we're doing. Thank you very much. I hope you've enjoyed listening.
Lucy, thank you very much indeed, and to Christine, both presentations, fantastic overviews of your services and importantly the impact you're having for patients and our communities. There is time now for questions on the service presentations. I'm just looking to the Q&A function. We'll give a little bit more time for people watching these presentations to submit any questions they may have. We have some time now, so we'll just wait a moment just to see if there are any questions. Haven't got any at the moment. We'll just wait a minute. Okay, I don't think we're going to have any questions from the public, so I'm going to hand back to Mark Day, our chair, to close. Thank you, Mark.
Thank you, Alex, and thank you to everyone this afternoon who has presented. It is greatly appreciated. And beyond just you that I wanted to thank, I really do want to pass on my appreciation to all of the staff across the whole of the Trust who work for us in delivering service to all of our patients and people that come into our care, because without your dedication and your professionalism on a day-to-day basis, we couldn't deliver what we do as a Trust. And so it really is greatly appreciated. It was a very dangerous thing to do on occasions like this, to single out any individuals, but there are just two that I want to mention. Firstly, as Julian has already stated, Martin Earwicker completed nearly 9 years as chair of this Trust, and he was a greatly liked chair who had tremendous respect and met with many of our staff, and all of those that I have met that spent time with him greatly appreciated his chairmanship, and he is going to be sorely missed. And so I just wanted to formally say thank you to Martin. The other person that I just wanted to slightly embarrass, because he is a very modest and has great humility, is our Chief Executive, Julian Ems. I don't believe today it's been mentioned that Julian was awarded an OBE in the Honours Awards during this period, and I think it was greatly deserved. But in typical fashion of Julian, he put it down very much as a team effort, and him just being the team captain that was receiving the award, and that the whole of Berkshire Healthcare deserves an award like it. But I personally wanted to say thank you for Julian, for his leadership, for his tremendous enthusiasm in terms of the way that he goes about his task in leading the executive team and the leadership team to provide care for our patients. So thank you, Julian. And I look forward to how things develop over the coming year and handing over the baton to the new chair when they're appointed. But otherwise, I will be attending to the AGM next year to see how the Trust has done. So thank you for your attendance this afternoon, and I hope that you found it useful. Thank you.